Hello, everybody. Welcome to PerfWeb 113, day one. So, as you can see, I am not Joe Basha. That's a good thing. um, I guess he will be joining us remotely. He's not in studio today, so you guys are stuck with me in the studio, but you won't be able to tell the difference. It's like he'll be here. I guess let's get started with what he usually does, which is the opening remarks. And the very first thing is if you want to contact us, there is an email right here-ish for you to contact us. It's contact@perfusioneducation.com. So any questions, concerns, anything like that, you guys are welcome to email us and we will get back to you. Secondly, there is this little crawling words on the bottom called a crawl bar. Usually we got all kinds of information down there. Check it out while we're doing this broadcast, and it'll have information. Next, we have the MediWeb app right here, and the MediWeb app. If you've watched it before, you'll know that there's two versions of it. There's a free version, there's a paid version, but basically it is a calculator, like an everything all-in-one calculator, especially the paid one, which is not too much. I think it's like $2 or $3. I don't remember the exact cost, but I bought it. It's great. I use it every day while I'm in, clinical cases. I obviously use the perfusion calculators of it. They have nursing calculators for drip rates, things like that. I use it on ECMO whenever it has a oxygen tank calculator that will tell you how long your oxygen tank will last. Of course, it has all your perfusion calculations, BSA, DO2, all the regular stuff. So check out the app. And next, we have PerfWeb podcast series. We can be found at most podcasts, I think, right, David? Most podcasts? Yeah, basically anywhere you want to listen to Spotify, anywhere where podcasts are broadcasted, you will find the PerfWeb podcast series. We also have newer podcasts. Where are those at, David? Okay, yeah. We also have newer podcasts. Vicky Carlisle does one. I do one. Vicky Carlisle does a At the Bedside one. It's about nursing stuff at the bedside. Mine's more educational. We have Becky Bolkovac does one. And also Vivian Moreno does one. And then, of course, we have Perfusion and Jeopardy, which I believe is our CEU credits. We're going to be having our second episode after we do these 2 hours. That one is done live. But so check that out. It'll follow right after we finish these 2 hours. And I guess with no further ado, let's see if we can't find where Joe is.
Hello, everybody. Yes, I am. Here I am. I'm here.
You're there.
Excellent job, Samir. Excellent job. I was kind of hoping you were going to do this is a special edition.
Oh my God! Why? Because you're not here.
Yes, that's what they do.
It is a special
edition.
edition.
You watch Fox News; they always have a special edition of Andy or a special edition. It's always a special edition when they're actually not there. So,
well, also it's special because we got the Perfusion and Jeopardy. That's like a newer thing we're doing,
that's
right?
True
like,
too.
So
that's going to be
super
our
special.
third right. So today the order is going to be ECMO, and really it's about circuitry. Even though I do talk about it, the title is why, when, and how, but we really are talking about cannulation strategies. That's the focus of today's conversation as far as this is concerned. And then our next lecture is going to be about weaning, how to wean VV and VA ECMO, and that's of course a seemingly a real challenge. It's not that hard, but it's seemingly a real challenge. What makes it hard is when a patient isn't going to wean, and I think we're confronted with that right now ourselves, right? We're dealing with that, but how you do it on patients who, you're trying to determine or assess their ability to take over either pulmonary, circulatory, or both, depending on the type of ECMO that you're doing, is really important. And I think we need to think that through. And I think I've put together a pretty good methodology for doing that from the evidence that is published. And then third will be our second Perfusion in Jeopardy program. And I know you feel you got robbed But I feel like I got robbed the first one. And remember, it is not the Perfusion Jeopardy show. It is the Perfusion in Jeopardy show.
I
So
love
you
it.
have to take that into context, right? It's not about really who wins or who loses. It's
No.
about the content. And to be frank with you, I really, even though I'm Joe, I'll be frank for the moment. I really think that the program provides some really good information
Oh, yeah.
on questions about topics and subjects that we really should know. We have to know them for the boards, but even I realized, wow, man, you forgot a lot of stuff.
Oh my God. Yeah.
And it's just such a great opportunity to really look at some of these things that we just forget about. When we're not having to work in that particular realm or arena very much anymore. So I think it's interesting. But listen, with all of that said, you did a great job on the opening remarks. I can't thank you enough for
Thanks.
taking over the seat
Absolutely.
for me while I'm away.
They made me sit
Today's
in your
program.
seat. I was like, I don't want to sit in his seat, but they made
No,
me
you
sit in your
have to.
seat.
But
Apparently,
I'm
I had
glad.
to. Yeah, I have
But
to.
today's program and tomorrow's program will both be with me. Well, actually, I'm not sure about tomorrow. I might make it back in time because the program tomorrow is at 4 o'clock. So I actually may make it to be in the studio. I'd still really like for you to be there
I'll
because
be there.
your
Yeah, I'll be here.
participation is always so appreciated.
No, I'll
And
be
I
here.
think
I'll
your
be here.
insight is really your experience and your insight. You come from a very unique kind of place, with
Yeah.
your medical degree, practicing medicine, being in a different country, and then also having gone through perfusion training here at a pretty well-established, well-recognized perfusion training program, and then working with us. I mean, you've been a tremendous contributor. So I think you come at things with a new set of eyes and a new perspective that has helped us as a group, I think,
Thank you.
all in all, get better. And that's ultimately what I need. I think the key to success is to surround yourself with the smartest people you can find, even smarter than yourself, because you've challenged me to actually be better. And I think that's something that's very beneficial to me. So let's just jump into this and get started. ECMO, it says why, when, and how. Again, keep in mind that the focus of this lecture is really about the ECMO circuit, cannulation strategies, and so forth. So keep that in mind. But there are going to be conversations about why and when and how. So those are included in this. I have no disclosures of any sort. I'm trying to advance my slides, David, and they're not going anywhere. Oh, there it goes. I have to click the right button. I'm sorry. So I'm going to show you a series of. Let me go back. So I'm going to show you a series of pictures. And I want you to think about what it is. You may not know what it is. You might know what it is, but just look at it. That's all I want you to do is look at it and try to figure out what it is if you don't know. So here's one. And here's two. And here's three. And here's four. Okay, and I put my best minds together. Here's five. So you might know five just off the top, off the rip, but just keep that in mind. So I'll just go through them one more time. I'm just going to go quickly. 1, 2, 3, 4, and 5. So again, put my both best minds together. What do all these things have in common? Okay, here's Joe, and here's Samir. He's a lot more studious than I am.
That's nice.
And this is Becky over here, trying to figure it all out.
With the paper in hand.
Yes, clearly. So the first examples, the first two pictures are electrical impulses from point to point. One was a computer chip, and the other was the brain, neurons. The third example was fluid and gas from reservoirs underground to a dike. Basically, it was an oil well, so a drilling platform. And they do directional drilling, and they can drill very far away, but that's what it is. The fourth example is a rocket engine, hydrogen and oxygen being mixed in all that configuration, all that piping to create thrust. And the fifth example, obviously, was the cardiovascular system. And so basically a circuit is nothing more than something that is taking something from one place and getting it to another place and vice versa. So it's a circuit is a circuit. It doesn't matter what kind of circuit it is. And there are things that influence how that works. There's physics involved. You have path of least resistance. You have, momentum. You have resistance. You have all kinds of factors that are mathematically, understandable, if you will, of how you make things, a circuit actually work. Some require is passive, some require energy. I mean, it's pretty straightforward. So when we talk about ECMO, we're really saying that it is nothing more than just a circuit, not dissimilar to what I just showed you. We're going to take blood from one place and we're going to do something to it in between, possibly not, but we're going to take blood and move it from one place to another using power, using different flow, just different pathways, different resistances, and get it to do what we need it to do, whether it be support the pulmonary circulation completely, or what the function of the lungs would be, or the systemic circulation, or both. So this is very interesting, and I want to bring this slide up because one of the things I'm going to talk about very quickly is I've heard people say, because I've seen ECMO done well and I've seen ECMO done not so well. And I've seen patients put on ECMO early. I've seen patients put on ECMO where it made perfectly good sense to do it. I've seen patients put on ECMO when I don't know why we're putting this patient on ECMO. This seems completely unsalvageable, not a salvageable situation. But one of the arguments that I hear is, well, if you have it, you have to offer it. And I want to get to that very quickly because that I think that I've heard that before and it's absolutely untrue. If you really don't feel a patient has an opportunity this is such a long shot. You have to remember that when you put somebody on ECMO, they could be there for a very, very, very long time because we are very, very good at keeping people alive on ECMO. But if they have no exit and you put them on ECMO, you've got a problem. But this argument that we have to put them on is absolutely not true. And I'm going to kind of get into that a little bit. But the criticism is the better your outcomes, the greater the criticism will be that if you had not put the patient on ECMO, they were probably going to live anyway. So they really didn't need ECMO if you put them on early. If you put them on really late, the outcome is almost always the same. They don't make it, in which case the criticism is ECMO was ineffective. What did you bother to do that for? So there definitely is a challenge with when do you put a patient on ECMO, because putting them on early can itself be a problem because ECMO is not benign by any stretch of the imagination. It can be life-saving, it can be life-sustaining, it can give the patient an opportunity to heal through whatever therapeutic modalities we can go through to help them with their infection or their whatever their issue may be that's causing this problem, another device, transplant, bridge, whatever it is. But the fact of the matter is that you can put somebody on too early and you can put somebody on so late that the outcome is predetermined. Too early, you can actually do harm. It is not a benign device. But where that cutoff is very subjective. I think there are some objective data that's published, but when you're the person at the bedside trying to make the decision, a lot of that stuff doesn't really mean a lot. Anyway, moving on. This is kind of what I'm talking about when they say, no, you have ECMO, you have to offer it to the patient. Mm-hmm. But so this night watchman was in London and he got really sick. And they drove to, after having tea, they drove to a hospital, they were vomiting, talked to a nurse. The nurse talked to the doctor on the phone who advised the men to go home and call in their own doctors. They left the hospital a few hours later. this Barnett dude was rushed to the hospital and died. They each had arsenic poisoning. His widow sued the hospital for negligence. And the court found that the doctor did, in fact, fail in his duty of care. He should have examined the patient, yet the claim failed because it could not be shown that Barnett would have survived even with proper care. The doctor was ethically culpable, but to establish negligence in law, the widow had to prove on the balance of probabilities that the doctor's breach of duty caused her husband's death. Now, I'm not saying that a patient is not eligible for ECMO because they're so bad, their risk of survival is so low. We shouldn't put this patient on this and consume this resource is quite equivocal, quite the same, but you can see the parallel that there is protection under the law to say this patient is not a candidate. Therefore, we're not going to put the patient on ECMO. I just wanted to throw that out there. Samir, you have any comments on that before I move forward?
Like you said, I mean, it's really tricky, you know. We've had those patients where we just don't feel they should be put on. We've had the patients where we're like, oh, maybe we should have got to them earlier. I feel, Joe, it's just it's right, especially in today's day and age, it's so hard to tell, you know, when do we do it? And because we've had ones where we're like, oh, we should never have put this person on, and then they recover, and you're like, well, okay, never mind. Clearly, I was wrong. And then, of course, we have ones where we're like, oh, well, you know, we should put them on, absolutely, and they died 2 minutes later, and we're like, okay, never mind, we were wrong. It's such a tricky road, but I feel you do got to be able to go somewhere, you know, and I'm sure you'll get to that. Again, it's got to be a bridge to something. If not, you know, you can't just.
No, it does. And to be honest with you, Samir, I don't have any answers.
I don't think there is an answer, Joe.
I think that what I think I'm trying to elucidate here is that they say, and this is, I've heard this before, and to be completely transparent, I've never, I can't say never, but it's extremely rare where I have said, this is a horrible candidate and we just should not do this, where they went on to recover and went home and had a normal life. I mean, I'm sure it's happened, but it's exceedingly rare.
It is.
And I've heard the argument, well, we have ECMO, we have to offer it to everyone. And that's fundamentally untrue. I think that was the point I was trying to make.
I agree with that 125%. That's not what it's for. Just because we have it doesn't mean that everybody qualifies for it just because they're sitting there dying. You know, you need an exit strategy, and that's the bottom line.
Absolutely. So I'll move on here with this why. This is a video. I probably won't play it all the way through, but it comes from Sharp, and I think it's a good video.
There's a couple of videos, by the way. Yeah, just so you know, I'm looking at the slides.
So I'm gonna just skip through it to make it quick. Everybody understands all of this, but I'll just get to here it is.
Here, hold on 1 second, Joe. Did they hear that, David? No,
What's
Joe.
the issue?
David is saying he doesn't think the audio worked, so maybe narrate it if possible, or explain what happened.
Let's go through that's fine. So you saw the fella. He went to a restaurant. He knows he has a peanut allergy, so he ordered the dumplings. And they were over there, he already ate them, but somehow it was contaminated with peanuts or got touched by them. He goes into basically respiratory arrest,
Sure.
ultimately cardiac arrest. They ECMO him, and he feels like he has two birthdays now, one before ECMO and one after ECMO. And then here, I'll just show you the picture of this lady. This lady was a patient that we did. She's been highlighted on the news, so this information is public. We don't have to be concerned about any kind of HIPAA violations here, but she was on ECMO for nearly 30 days during COVID. She was a Zumba instructor, was moving here from Los Angeles, and contracted COVID while she was here and had a horrible reaction. It was during the Delta variant, and ultimately she went to work at the hospital as a volunteer, and she's still around and doing great. And this lady was tough as nails, but she was one of those patients that around day 15, 16, I started having some serious doubts. She had massive hemorrhage from her mouth, from her nose, from her just her entire oral pharynx, and then she started having other bleeding as well, severe menorrhea. It was really tough to deal with her, but she was very tough, and we got her up and walked her around on ECMO, and she did incredible. But she was in very bad shape. Her compliance was so bad that 150 cc tidal volume was giving peak pressures of 45 and 50.
Oh my God, that's barely anything.
So she had literally no pulmonary compliance whatsoever. But CT'd her several times, and Dr. Keevlin kind of took this patient for himself and was like, I'm not going to let this lady die. And he did serial CT scans, and he said there is no fibrosis, so this is still reversible. And that was what he used to continue this on, and she did great. So moving on from there, where do we do ECMO? Well, traditionally it's in hospitals. When it's in the emergency room, that's actually really kind of a big deal. But you look at the European model, specifically in Paris, and they're doing this in the Louvre. The Louvre. They're doing this not in the Louvre. I guess that's the bathroom. But the Louvre. They're doing this at the. They could. They're doing this in the subway. They're doing this in the grocery store. And I don't know if you could notice or not, but there's a patron back there trying to get himself some milk, and they're just putting this patient on ECMO. And this is real.
It's like a mobile ECMO unit, right? I think that they have like over there. Yeah,
correct.
Mobile ECMO unit.
They have an ambulance, and they go everywhere, and they put these patients on ECMO. It's really pretty impressive. In this particular slide that you see here, and it's a somewhat dated slide, but you can see that the number of ECMO centers has been on the rise. But if you take a look, and this is from the ELSO registry centers in North America, comes directly out of ELSO. But I think this next slide is what is really telling us the story. Okay, so that was a little dated. Okay, that goes back to about 2018. But then we had COVID happen. So this is going out to about 2021. And this is for respiratory failure only. But look at the growth of ECMO and the projected growth of ECMO, which has actually occurred for VV ECMO, and you can see that it is very high. The upward trajectory is very steep. And so I think people are doing more and more ECMO, and we're getting better and better at it. And I foretell a day where ECMO is going to be pretty much like putting somebody on a ventilator is today. So I think we're going that direction. We're pretty close to it, I think, right now, and I think we're going to eventually get to that point. Indications: cardiogenic shock, acute coronary syndrome, cardiac arrhythmic storms, refractory to any kind of medications, sepsis, profound cardiac depression, drug overdose toxicity, myocarditis. That has a great outcome associated with the use of ECMO. PEs, isolated cardiac trauma, anaphylaxis, as you saw with the young fellow with the
Yep.
peanut allergy, post-cardiotomy, inability to wean from bypass. We're seeing it used more liberally in those circumstances as well. Post-transplant, where you have PGF, and especially after heart or heart and lung transplantation, chronic cardiomyopathy as a bridge, in which case to longer-term VAD support, or a bridge to decision, which of course the decision can also be withdrawal. Peri-procedural support for high-risk percutaneous cardiac interventions, such as TAVRs. We're using it for that, and we're also using it for doing keyhole incision, single lima to the LAD, where the patient needs some additional circulatory support to do the anastomosis carefully. When you occlude that LAD, if it's not 100% occluded, and now all of a sudden they're starting to have EKG changes and hemodynamic instability, and then of course bridge to transplant. So there's a lot of opportunities to use this. Indications for respiratory support are fairly straightforward. Any kind of pneumonia, whether it be bacterial or viral. Aspiration pneumonia is very, very common. You have alveolar proteinosis. You have assistance with lung rest for airway obstruction, which can be, of course, from an allergic, from anaphylaxis. Pulmonary contusion, smoke inhalation, the fireman that goes into the burning building and the respirator doesn't work and they inhale a tremendous amount of smoke, and now they're in frank pulmonary failure. For lung transplant, again, PGF. Bridge to lung transplant, intraoperative ECMO. For lung transplant, status asthmaticus, pulmonary hemorrhage, and massive hemoptysis, which is a kind of iffy because you're going to have to do non-anticoagulation ECMO. We can talk about that as we move on, especially in the weaning. I have a lot of that in the weaning aspect of this, and other things like diaphragmatic hernia and meconium aspiration. So here is a nice little kind of thing that helps you to decide what kind of ECMO do we do. And I think what is really important about this is if you have cardiogenic shock, okay, cardiogenic shock, and it is due to hypoxemia, you don't do veno-arterial or veno-arteriovenous ECMO. If your cardiogenic shock is due to hypoxemia, do VV ECMO. Now, the reaction is usually we need VA ECMO. Right. But if you do VA ECMO, the heart is going to recover quickly, and you're going to end up going, oh, hell, our lungs aren't working, and now we have Harlequin, so we have to do VAV. Right. If you know the cardiogenic shock is secondary to hypoxemia, do VV ECMO. I think that's the takeaway from this slide. Indications, your Murray score greater than 3, PF ratio less than 100 despite high PEEP, hypoxic respiratory failure due to any cause, primary or secondary. ECMO should be considered when the risk of mortality is 50% or greater, as would be calculated on the various calculators that exist, and is indicated when the risk of mortality is 80% or greater. 50% mortality risk is associated with PaO2 of less than 150 while on a ventilator, FiO2 of greater than 90%, and there's an 80% mortality risk associated with PaO2 of less than 100 while on ventilator of greater than 90%. So here are your acute lung injury, acute respiratory distress, PaO2, your PF ratio less than 300, PF ratio less than 200, and normal equals PF ratio of 500. So you can see at 300, it is you should be considering it. At 200, you should absolutely be it is indicated. And here's your Murray lung score and how you figure that out. So it's on there. You can look at it at your leisure. Here's a little chart that you can print out or make a copy of, and it gives you your PF ratios. But I mean, it's not a very challenging calculation, so you can do it either way that you want. Your calculation is PaO2 divided by FiO2, and there you go. So it's pretty simple. So let's talk about CRRT incorporated in the circuit. Actually, I'm going to bypass that. We're going to go straight to VV ECMO. We can go back to this if you want to, but I don't think we need to for the sake of this lecture. So let's look at VV ECMO. There's a whole bunch of different ways to do VV ECMO. In this particular scenario, you see you have an access line, the arrows going this way to the centrifugal pump and then to the oxygenator back. You're draining from the inferior vena cava, and you can see that they are infrahepatic, and returning to the superior vena cava, actually directly into the right atrium about the mid portion. You will have some recirculation, but as long as you're about 15 centimeters away from tip to tip, and this is in fact in the atrium and not all the way down here, and this is in fact in the IVC below the hepatic vein and not all the way up here, your recirculation is going to be minimal. Every VV ECMO, no matter your technique, will have recirculation with one exception. There's only one exception where you will not have recirculation in your VV ECMO, even with bad, poor cannulation. And that is on a patient that is severely hyperdynamic. If their cardiac output is 12 and 14 liters and you're flowing 4 or 5 liters in your ECMO, the washout is so fast that you really don't have any recirculation. That is the only time you would see recirculation of 0. The time you would see recirculation that is very, very high, despite perfect cannulation, is when you have heart failure, cardiac failure, or you are flowing higher than the patient's cardiac output. So if the patient's base cardiac output is 4 liters and you're flowing 6 liters in your ECMO, easily you can understand you are going to have that percentage, at least that percentage, roughly 20%, recirculation just from that, even with perfect cannulation. Does that make sense?
Makes sense.
Okay, good. So here are the various different cannulation techniques. You have where you have both inferior coming from the contralateral femoral vein from the other. You have your access down low and your return up high, and you're taking advantage of the natural flow of venous return going in that direction, right? Makes sense. Here you have this is a little bit higher than this, and you're going to have more recirculation in this than you will here. Now here you see this cannula, it's a little higher than the hepatic vein, and your return in the mid portion of the right atrium. I would want to pull this back some, but this is another technique, and this is just illustrative of the same technique using just a different cannula. This one has fenestrations farther down, and this only has the fenestrations, the multiple fenestrations up more towards the tip. So you have different types of cannulae that you can use, and I think that's what they're showing here. The Avalon or the Crescent is both are dual lumen single cannula techniques. The difference is the Crescent is longer than the Avalon. The Avalon was the original, then bought by McKay, and the Crescent was made by MC3, distributed by Medtronic. It is longer, so it is more amenable, though off-label, to be inserted through the left subclavian vein into transition it across the innominate vein into the SVC and then down through the atrium into the IVC. But ultimately, they both do the same thing, and that is you have drainage ports in the vena cava, and your return port is in the right atrium. If you can position it correctly so that the outlet jet is jetting towards the tricuspid valve. To insert this, you must use fluoro. To assess its proper position, there's 2 ways to do it. One is through echo. You can't do that with fluoro. Through echo, or through using the transonic ELSA-meter, which I think I'm going to talk about tomorrow, why that should be a standard of care on every ECMO, whether it be VA or VV. okay, because it measures, we'll discuss that a little farther. But very important to know that you cannot insert this cannula. You can do it, it's dangerous and shouldn't be done with echo. It should be inserted under fluoro for safety, and it should be assessed using TEE, its position. And here you see how it lies, and there's a where these lines Y off. In both of the cannulas, you want the return to be anterior, and the access to be posterior in this configuration. This is proper placement so that this exit port is rotated towards the tricuspid valve, because or medial, which would be towards the tricuspid valve. The Protect Duo is a cannula that I have experience with it. I don't have contemporary experience with it. They claim that your flows are up to 3.9 liters. Actually, they claim you have flows up to 5 liters. I've never used it and been able to get flows above 2.8 liters, but it is certainly a good cannula for mild to moderate, well, I would say moderate, right heart failure. So if you have you have your post-pulmonary emboli, your right heart has taken a hit, maybe post-cardiotomy where you didn't protect the right side very well, and your right side has taken a hit and it's going to need 5 to 7 days to recover. It's still working, but it was strained. This is actually a very good cannula, I believe, for that. If you only need modest support, pulmonary support, then I think it's a good cannula for VV ECMO. But again, only if you need modest support. For full support, I do not recommend it. I've not had good experience with it, and I don't feel that it is well adopted. I don't think it's adopted and used a lot. I think it's used in very select circumstances, which is appropriate. It has a place. It is not, but you have to understand what its limitations are. Here's a standard X-ray showing the Avalon cannula's position. And you have your, this is looking at one of the drainage ports. There's drainage ports down here, and this is pointing towards where the exit would be. It's not necessarily the best diagram with the best arrows, but that's basically what you expect an X-ray to show. Your diaphragm is about here. You can see that this tip is definitely infra-diaphragmatic, and you want it to be that, but you just don't want it to be all the way down here. The further down this tip is, the further down the access is, and once you get your access down into this area, well, you know that you're going to be looking at basically sucking out of the right atrium, which is where you're also returning, so you'll have increased recirculation. Here's another, this is VA ECMO now, changing to that. You have access coming from the mid portion of the right atrium, returning to the femoral artery. You also have access from the SVC, returning to the carotid. You see this in children. They sacrifice one of the carotids for their ECMO return. And then you have here central cannulation, where you're coming directly out of the right atrium and going back into the ascending aorta. There is a place in Chicago, I don't know exactly which hospital it is, but even in patients that are not post-cardiotomy, let's say ECPR from the ICU, they immediately do a sternotomy and everyone gets centrally cannulated, and this avoids the risk of Harlequin syndrome that does occur, well, actually with VA ECMO, with peripheral cannulation, you always will have Harlequin syndrome. Whether it's clinically significant Harlequin syndrome occurs approximately 8 to 10% of patients on VA ECMO will develop Harlequin syndrome clinically significant enough to require intervention vis-a-vis a conversion from VA ECMO to VAV ECMO. That's the data. Those are the numbers that are published. Here's what typical peripheral arterial cannulation looks like. I'm going to show you a diagram at the end, which I think is fun, to entertaining to kind of look at. But you always remember that arterial is always going to be lateral because it goes nerve, artery, vein, ligament. The naval, well, I guess you have empty space, nerve, artery, vein, empty space, ligament, vein, ligament. And so you have that acronym to describe. So your arterial return is always going to be more lateral, and your venous access is always going to be more medial. And then you have this line coming here, going into the superficial femoral artery, or SFA, perfusing for the lower extremity. I'll show you some more information on that. And that helps to preserve leg perfusion and reduce limb ischemia. And I'll show you some pictures of what that looks like. Here is typical central cannulation. And I want you to look at, what I want you to really look at from this is look at how not only distended, because that's not all you see here. To my eyes, this is massive, massive cardiac edema. The tissue, this patient is so incredibly fluid overloaded, and this is such an obvious illustration of that. This patient needs to be given a lot of 25% albumin and very, very, very aggressive hemoconcentration. That would benefit this patient and this heart tremendously. But this is what massive cardiac edema really looks like. This is not just distension. Here you see how they run the lines, usually on central cannulation, so you don't have to leave the chest open. You can approximate everything, and you tunnel the lines in much in the way you do chest tubes. Let's talk about some exotic cannulations. You have femoral vein to femoral artery, or coming here, and then you also have your wide access from the superior vena cava. So you have SVC drain, IVC drain, returning to the femoral artery. So this is double access, or VV-A. So veno-arterial ECMO, and wherever the dash is where the oxygenator is placed. So veno dash A through the femoral artery. In this particular scenario, you have access, you have veno dash arterial. So you have VAV ECMO in this particular case, because you have it going back into the artery and then coming back into the right atrium. So this is VAV dash AV ECMO. And this is what you would do if you were just VV and you developed Harlequin syndrome and you needed the additional oxygenation for a pre-lung. You would do it in this configuration. So here we have some fun diagrams. This is an example of VVA. We just talked about that. Venous drainage, one arterial return, VV, oxygenator A. Here's another example of VVA. Both femoral veins are being drained from the vena cava, going back into the femoral artery. Here you have two superior lines draining the venous blood going into the arterial. And in this particular one over here, you have one venous drainage and you have arterial return and venous return. We just discussed, that's exactly the one we just discussed. You have VAV with a different configuration. You have one venous drainage, you have arterial coming back to the femoral, and the arterial coming back here, very similar to this one. Then you have VV-AV. You have two venous drainage going into the oxygenator, so there's the dash, You have one arterial return here, and you have an arterial return to the venous system. So 2 venous drainage, 1 arterial return, 1 venous. So you didn't have enough drainage with 1, so now you have 2 drains for the venous. You're going into the arterial and for systemic circulation, and 1 going into the right atrium for pulmonary support. Then you have VVAV, same exact thing that we just talked about, only in this particular case, it looks like we are draining from the femoral vein and from the superior vena cava, and we are going back into the femoral artery and then the contralateral femoral vein with the cannula all the way up into the right atrium. And then here, you really needed a lot of venous drainage, so you have bilateral venous femoral access. You have jugular or superior vena cava drainage, so VVV oxygenator and 1 arterial return. So those are some interesting diagrams, gives you an idea, and it goes straight back to what I was talking about before. It is a circuit. Let's talk about this very briefly if we can. I wish I could do with a pen, but I can't. I can't write on this. But with that said, I'm going to use this circuit, I'm going to use this circuit here. Your venous drainage is your venous drainage. Going back, you have return here and return here. Normally, an ECMO is going to have 1 flow probe. But in this particular case, you need 2, at least 2. So you could, in theory, put your ECMO flow probe here to measure your venous access flow for just to have it. But your return, you want 2 probes, 1 here and 1 here, so that you know which of these you're flowing to and how much. It's probably more relevant in VVAV because you definitely want to know how much am I flowing systemic, how much am I flowing back up to the right atrium. And that's where we're going to talk about the transonic. That's a double flow probe system, and that gives you access then to 3 flow probes for when you start getting really interesting types of configurations. Now, let me show you this. We talked about how, you know, the cannulas are placed. It's nerve, artery, vein. The vein is always going to be medial, and the artery is going to be lateral, and the same thing on the other side. So this cannula is flowing this way, and it's connected with this Y connector, and if I follow it up, it's coming to right here. Okay, both are medial, both are draining, both are in veins. So you have both sides draining, and you have the arterial. Here's your Y connector. The return's coming this way, and it's going into this artery, and it's going over here into this artery. Now, you can clearly see this is darker than this, and this are the same color as this. We know this is arterial. We know this is arterial. We know this is venous. Why is this brighter than this? Why is this the same brightness as this and this? Anybody can answer that question? You win a special prize. So whoever's monitoring the YouTube chat or the PerfWeb system or whatever, Facebook, LinkedIn, tweeters, the X-tweeter, whatever it's called, see if anybody gets that. Samir, where is it? Da 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 da.
Let me think.
Da 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 da.
Not an intracardiac shunt, is it? PFO, no.
Da 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 dun, dun, dun,
It's the music.
dun. Did the music. Okay, did
Uh,
anybody answer Magic or David? Anybody on the other sources?
he's checking. Yeah, he's got somebody that says he's putting it up.
I can't see it.
He's pulling it up. He said somebody answered. Hold on 1 second. Let me see if I can't see it. Recirculation.
Bonk.
Nope.
No,
And then
I'm
the other
sorry.
one-
How much did they wager?
they didn't put a wager. Another one is
Wrong.
the oxygenated blood going in is being drained out of the venous line.
Nope.
Nope. Okay.
That line is going up the femoral vein,
Mm-hmm.
into the right atrium, transeptal, and is draining the left atrium.
Ah, okay.
That's why it's red. Good. Nobody got it. I don't owe anybody any prizes.
There you go.
Common cannula complications. This is what poor perfusion looks like. You don't put an SFA line in, or worse, you do what somebody I saw do, and you put an SFA line in that's not in anything and infiltrated, and oh my God, fasciotomies, and we lost that leg. They lost the patient too, but this is what it looks like when you don't do an SFA line, and you have no distal or very poor distal perfusion to the limbs. Here you see a common setup for it. I'm glad to see they don't have a stopcock on here. Never, ever, ever put a stopcock here. Never, ever, ever put a stopcock here. I'll say it again. Never, ever, ever put a stopcock on a solid connector. You break it and you can't fix it. You can't get the piece out that gets left behind. I also am very happy to see and very impressed. So this is venous, this is arterial. I'm very impressed to see that they're using NIRS on the calves, on the periphery. That's a standard of care. Everyone should use that for the limbs and for the head. Other things you have to be concerned about is cardiac. I won't read all of this, but you have to be very concerned about cardiac distension. When you're on VA ECMO, you are increasing the afterload on the LV to eject. And if you do not have good anticoagulation and your aortic valve is not opening, you can get thrombus in the aortic root, but also in the LV as well. So it's very important to vent the LV. That's why these people put that cannula in. They didn't have Impella or whatever, or couldn't put Impella in because maybe it was a mechanical aortic valve. I don't really know. But this is how you can reduce the distension of the LV through a transeptal puncture. Here's another example of what we frequently see, and you can see that you can have an SFA line in either side. You can run these things any direction that you need to in order to accomplish your goal of peripheral cannulation. Here, this is either a balloon. This is a balloon pump. This is not Impella. So this is a balloon pump here, but it's also obstructing the artery, and so they put this in the SFA line, just quite distal. This is an example of what you might see VA ECMO without an Impella in, and you can see that the septum, the intraventricular septum is deviating into the right ventricle. It's very, very distended, very big problem to leave this like this. And here you can see with the Impella, we call it ECPella, I think is ECPella is the name that we use now. And the CP is generally a good device for venting, but you can see now the normal geometry of the LV. The septum is normal, no longer deviated into the right side. This gives you an idea of wall stress and how that can be a problem. VA ECMO alone, quite high. Tandem heart, which is the transeptal puncture, and Impella 5.0. And Impella is definitely better, but this is better than this for sure. How much better it is, I don't really know. I can't really tell you. This is what it looks like. A schematic drawing of is what an X-ray would look like, and this is an overlay, so you can see the impella coming in, and the tail of the impella is here, and this is representative of this pigtail. You can see that pigtail here, and then you have this part here, which is what you see right here, and then you have the motor here, clearly above the aortic valve, which is what you see here. So this is this, this is this, and this is this. This is what you would see on typical X-ray when you're doing your morning X-ray or whatever, and you're trying to assess where everything is, or after placement, as the case may be. This is that cannula that I showed you. You can see it coming up through the inferior vena cava, dumping into the right atrium. There's your coronary sinus, and there it is going transeptal, and here's your drainage here. So this will help to keep this decompressed, not as well, but pretty well. And this, of course, is the tandem heart, and this is the Protect Duo that you see there. And tandem really doesn't exist anymore. They sold to LivaNova, so a lot of this is somewhat dated. Keep that in mind. Here's Harlequin syndrome, very common phenomenon. You always have it. Its clinical significance is determined by, by various different metrics, and that's going to be where it is truly. You have to truly intervene is about 10% of the time. But what's so important is that if you are on VA ECMO, so you have to have certain elements in order to have Harlequin syndrome. The first element is you must be VA ECMO. The second element is you must be VA ECMO with peripheral femoral cannulation. The third element is you must have insufficient pulmonary function, whether that be because your ventilator is not set, which we have actually seen, or because the lungs are sick. There's something wrong. So very important that if you're going to measure your blood gases, or you're going to put a pulse ox on, that you put it on the right hand. And the reason for that is it's the artery that is farthest away from where your cannula is. If you put it on this arm, your left arm, in theory, your mixing cloud, which you see here, could be right here, and your left pulse ox is reading 99%, but your right pulse ox is reading 62%, 72%, inadequate. And you don't know that because you're not measuring it. And this is dividing, this is your innominate, and divides to your right carotid artery. This is your left carotid artery, and then your coronary. So you could be getting inadequate cerebral oxygenation while still believing that you're okay. Don't be this guy. Never use VA ECMO with peripheral cannulation for poor pulmonary failure when there is no LV dysfunction. I don't have to say anything else. Don't be that guy. VA ECMO survival, and I'll go through a variety of things. Literature ranges between 20 and 30% among patients who receive VA ECMO for cardiac arrest, severe cardiogenic shock, failure to wean from cardiopulmonary bypass. This is in one study. I think the numbers are actually higher than that. Shin et al. Demonstrated that ECMO performed for cardiac arrest was associated with increased survival with minimal neurologic impairment compared to conventional cardiopulmonary resuscitation. These findings were confirmed by Shin et al. At discharge time, 30 days, and 1 year survival. The SASAR trial, we all remember that. This came out of the H1N1 epidemic. It was very polarizing. It had mixed reviews. Yes, ECMO really helps. No, ECMO really doesn't make any difference. It was essentially inconclusive, and it depended on what you wanted to read into it. I don't think it did ECMO any favors. The Eolia trial, and I think this is again the same thing, because you really have some real challenges in this because of timing, method of performing ECMO, cannulation, intensive care treatment following cannulation. There's so many things that go into ECMO that this ECMO center and that ECMO center can be so incredibly different as to their outcomes, patient selection, all of these things. There's so many factors involved that it's very hard to really take any of these trials. But basically in EOLIA, there was a 20% absolute risk reduction in compared to standard care in terms of either mortality or survivability of, or 20% reduction in relative risk reduction in mortality with patients that used ECMO. However, that also suggests possible clinical benefit from ECMO or standard care, especially if used early rather than late. So a 20% absolute risk reduction, they did not believe was sufficient, but if you do it earlier, your outcomes definitely are better. So we get into that same thing that I started from the very beginning with, you're damned if you do, you're damned if you don't. But compared to standard therapy, including prone positioning and neuromuscular blockade, it had a higher rate of failure requiring rescue with ECMO. And basically, this is really the data when it's all pulled together, meta-analyses and everything else, and we're only going to be looking at adults. I'm not looking at anything else, not going to go to ECPR, even though that's actually quite good. We're just going to look at pulmonary and cardiac, and I'm sorry, we are going to look at ECPR, not pediatric. No neonatal, no pediatric, only adult, and those three categories, pulmonary, cardiac, ECPR, my mistake. 60% survival, 42% survival, and 29% survival. Those are generally going to be what is quoted a family member when they are confronted with, we need to put your loved one on ECMO if they're going to survive. Well, what's their chances of survival? Well, if it's VV ECMO for pulmonary, it's going to be 60%. If it's cardiac, whether it be post-cardiotomy syndrome or whether it be an MI and cardiogenic shock from an ischemic event, acute coronary syndrome, it's going to be 42%. If it's ECPR, they came into the ER, they were having they were on the thumper, and you put them on ECMO, it's going to be about 30%. Those numbers, when you look at those, given that without it, the mortality is going to be 100%, that's pretty doggone good. And so you can look at the individual trials, but really you have to look at all of them with a comprehensive meta-analysis, which is what's done here, to get some numbers that actually mean something. And it helps to filter out the disparity in technique. What's the future? I think ECPR is here to stay, doing this in the ER. Will it happen in the field in America? I don't know. For TAVR, we are doing it for TAVR a lot. TAVR support, it's making it much easier to do these procedures if the patient becomes unstable and they don't have to rush, they can take their time and they can figure things out. High risk PCI, I think that we're gonna see more of it for that. Balloon valvuloplasties, for normal VV for sepsis and trauma, myocarditis, it has great outcomes. I think we've already proven that. Post-cardiotomy syndrome, no one's going to want their patient passing in the operating room. We're going to see more and more of that as we continue to do these more complex and sicker patients. And one thing is for sure, ECMO can, I don't know what, one thing is for sure. I'm not sure what one thing is for sure, but let me show you some slides of oxygenators that fail. Here's a video. I think you can see it. You can't hear it, but that is a polypropylene fiber oxygenator. And this is what a wetted oxygenator looks like. That just has to be changed. Your CO2 clearance is going to be terrible, and eventually your PO2, your oxygen transfer is going to fall, and it's going to be a crisis. So you see something like this, you have to change it, but that's what it looks like. And that's caused by lipids in
All right. I think we're back. I see me on. Yeah, I think we're back live. Is Joe back on?
I'm here.
All right, Joe. I think we're back on, buddy. Yeah, if you want to pick up right at the oxy failure where you were
Well,
talking
I'm
about
gonna
lipids.
actually, sounds good. So I'm gonna go right back here. One thing is sure, which is what I forgot, was that
You
ECMO
remember
is here
in the
to
time
stay,
that
and it's continuing. Yeah, I remembered. Thank you for the power surge. And the ECMO is here to stay, and it's going to continue to grow. So going back to the oxygenator failure, I was talking about this plasma leak. This is a polypropylene fiber. Polypropylene will interact with lipids, something you have to be very aware of. So you have
Yeah.
a patient, and you don't have to have them on propofol, but do not use propofol if you're using a polypropylene fiber, because what happens is it changes its molecular configuration from naturally hydrophobic to hydrophilic. The plasma water, fills the polypropylene fiber, causing it to swell, expanding the hole, allowing for plasma to leak out. That's why you see this. The polymethylpentene is a sheathed fiber, and it does not interact or react to lipids. You can use lipids in those, but this can occur without use of propofol and a patient that is just hyperlipidemic. So very important, during COVID, we had to use a lot of polypropylene fibers, and some of them lasted 10 to 12 days. I had one last almost 20 days, but I've also had them last 2 days. I've had them last 24 hours without the use of propofol or other lipid agents, just because the patient was hyperlipidemic. So that's what it is. That's what causes it. Any comments, questions, or concerns? I can't see anything, so I have to rely on you, Samir, completely.
Yeah, I'll let you know.
I wish I was here.
It's funny that you
Now,
bring up
it's a little barren,
Yeah, it's
but I
okay.
still would prefer to be here right now.
Sure. Well, I mean, a comment. Very first oxy change out I ever did with you there was because we had propofol given on a PMP, on a polymethylene fiber oxygenator. So just throw
No, a
that interesting tidbit
non-PNP, a
out.
non-PNP,
Sorry,
a
a non-PMP. Yeah,
non-PNP,
non-PMP.
right? A
But yeah,
polypropylene fiber.
very first one
Yes.
I ever did was because of that.
Yes. Okay, anybody else, anybody from the audience have any questions?
I do not see any currently.
Okay, let's move on.
All right, buddy.
Weaning and liberation from ECMO. Clinical protocols, physiological readiness, and decannulation. There's a lot of very good ways to wean patients off of ECMO, VV or VA, and they're well established. But there's also really bad ways to do it, and people still do these things. But we're going to talk about it anyway. So some of our objectives are to understand the physiological foundations, veno-venous protocols, circulatory and ECPR protocols, and liberation from surveillance and complications. So that's kind of the direction we're going to go. Physiology workload transition to native organs and veno-venous. The weaning physiology, you want to shift the pulmonary workload. The goal is transferring entire gas exchange, oxygenation and CO2 clearance, back to the native lungs. Your pump flow safety, the beauty of it is that you can leave your VV blood flow as high as you want. It doesn't matter. It's a shunt. That's it. So if you're at 0, there's no need to turn your flow to 1 liter, especially if you're doing a very low or even 500 cc's, anything below 2. You could leave it at 5 liters. If you have no gas flow at all, it doesn't matter. It's a shunt. But if you're doing low anticoagulation protocol or no anticoagulation protocol, you've got to be very careful. You don't want to thrombose your system. You titrate your sweep flow to primarily stress test for your native ventilation and respiratory compliance and flow dependency. Arterial saturation depends strictly on the ECMO flow, patient cardiac output ratio. In veno-arterial, your weaning philosophy is dual workload focused. Native system must take over both left ventricular cardiac output circulatory and gas exchange. Your flow reduction trial requires stepwise blood flow rate reductions to 2 liters per minute as your floor. You do not want to go below this. Now, if you're really anticoagulated, your PTT is above 200, or immeasurable, like would be on bypass, well, that really doesn't matter. You can get away with it. But frequently that is not the case. Your PTT is going to be between 50 and 70, somewhere in that range normally, maybe down around 40. It just depends. If you follow ACC, the SCCM guidelines, it's 1.5 baseline. Retrograde afterload peripheral VA ECMO increases afterload on the LV, risking LV distension and pulmonary congestion, so you have to keep that in mind. And multimodal echoes, requires rigorous echocardiographic tracking of the aortic valve opening and the LV size as you are continuing to wean, because you're going to start seeing, if they're going to fail, you're going to see it on echo very, very readily. You might be messing with the drips, titrating this, titrating that, and your hemodynamic monitor could give you a false sense of success. You really need to be doing echoes, and you need a good echo sonographer. VV criteria prior to trial initiation. Your clinical milestones that you're looking for is resolution of your primary lung pathology, systemic normothermia is achieved, hemodynamic stability, minimal use of vasopressors, and inotropy, patient cooperation, sedation is optimized, respiratory muscle activity is returning. So very important. I think I say this several times throughout this lecture, that if you start seeing a patient using all of the accessory muscles, they start shoulder breathing as well as just their diaphragmatic normal breathing patterns, then you're probably going to have a failed withdrawal or failed explantation. Reversibility is the substantial improvement in primary disease. You've got the infection under control, must be evident. You don't want the patient heavily sedated. You need them to be able to breathe normally and be able to. You don't want to suppress their respiratory drive, and you want them also to be participating in this process. Hemodynamic compliance, standard circulatory goals, a mean greater than 65 with minimal and stable vasopressure requirements. Timing guard, avoid premature trials during hyperdynamic sepsis or high inflammatory phases. In other words, don't be in such a hurry to get the patient off of ECMO. You put them on VV ECMO, let's get their disease under control. Let's get their infection resolved, and then be able to move forward with considering weaning. You have to make sure that their breathing muscles are actually working, and that's very important as well. There's different ways to do it. There's intubated and intubated. So you have an FiO2 limit. You're going to say, okay, we want to get down to 40% FiO2 on the vent. That gives us some upward mobility, but to wean, actually terminate, you need it to be less than 60% or less on the mechanical ventilator. You want to set your PEEP limit. You want it really to be equal to or less than 10 for a weaning trial. And this is if you're going to keep the patient intubated. You want your PaO2 at these settings to be at least 70, maintained under protective ventilatory rest settings, because you're still going to want these lungs to rest if you're going to this patient's going to stay intubated. And you want to make sure that you don't overtax the alveoli, starts trying to get more barotrauma or recruiting tissue that's just not ready to be recruited yet. So you want to keep your stretch to a minimum. Awake and non-intubated, totally different situations. Supplemental O2 limit. receive no more than moderate flow support, standard cannula limit. You want there to be on your nasal cannula equal to or less than 6 liters per minute, or face mask. If you're high flow, you want your limit to be 40 liters per minute with FiO2 equal to or less than 30%, with a target PaO2 of equal to or greater than 70 under spontaneous breathing. And the physiological Y, protective thresholds. These parameters ensure that once ECMO support is removed, the native lung can sustain oxygenation without exposing the alveolar tissue to very high, obviously, FiO2s, which is toxic to the tissue, or high barotrauma if you have to push, go up on your PEEP and go up on your tidal volumes with positive pressure ventilation. You want there to be a systemic reserve, confirms baseline functionality of the capillary alveolar surface area and maintaining that as intact, and transpulmonary safety. Spontaneous efforts must not generate excess transpulmonary forces. You don't want these patients struggling to breathe. You don't want them drawing excessive negative pressure. These are all bad things that will happen that will cause your now weaned patient to fail. So you don't want that to happen. So these guidelines are pretty straightforward, I think, if we follow those. And these are all published, and you see down below the reference for these. Ventilator thresholds, tidal volume equal to or less than 6 milliliters per kilogram of predicted body weight. That's very important. Not actual body weight, but predicted body weight. That's key. Plateau pressures equal to or less than 28. And then respiratory rate equal to or greater than, or equal to or less than 28 breaths per minute without accessory muscle recruitment. Again, when you see them body breathing, that's a very bad sign. They're tachypnic, it doesn't look good. They're not going to be able to sustain that. Acid-base stability, you want your pH, PCO2 to be normal under native load. Again, remember, you set these parameters, you've got a little bit of wiggle room. You need to make sure you have some upward mobility. So you don't want to say, you know, we're going to decannulate when we're at 60%, because now that next step is 80%, then 100%. 40% gives you a little bit more wiggle room. Minute ventilation can maintain normal capnia without excessive minute ventilation. That's very important. You want to look at the chest x-ray. Is it clear? If you've got the edema resolved, the infiltrates, or if there were contusions, those have all cleared. You have an absence of pathognomonic excessive drive, in other words, high minute ventilation, tachypnea. We'll just leave it at that. Spontaneous control breathing during ECMO is physiological, but must be monitored. Short efforts are protective. So you want people to even breathe normally while they're on ECMO. We can do that. We do that a lot. We take these patients and walk them around. Sometimes, if you're walking a patient on ECMO, I'll tell you what I've done is, especially in the early phases when they're just starting to, I will see them starting to struggle breathing, and I will turn the sweep up, because that struggle is going to come from CO2, and I know that. And I can watch their breathing improve dramatically. And this is very important. I'm not trying to cheat them out of not being able to breathe on their own, but I need them to be able to condition so that they're not so deconditioned they can never be decannulated. So it's a balance between the two. Here's a ventilator challenge mechanics for stress testing. Standardized ventilator challenge trials are mandatory to test respiratory compliance, prevent weaning-induced injury. These differ based on the selected ventilator mode. So here's your assessment dimension, your volume-regulated challenge, and you can look these over, and your pressure-regulated challenges. So if you follow these guidelines and these various metrics, then this is a safe way to stress test your patient's ability to breathe on their own. VV de-escalation for the oxygenator. Remember, that you do have to, obviously, if you're flowing 4 liters a minute, you're treating more blood. But when you get down to zero, then it doesn't make any difference what you're flowing. At that point in time, it truly is just nothing more than a shunt, a loop. But you want to look at your target parameter, your FDO2, how much oxygen you're delivering, your floor weaned down to 21% room air on the blender, and that means you have to have flow. You can't be at 21% with no flow. You're truly zero then. Any sweep gas at 21% is still adding oxygen to your circuit, because oxygen isn't ever added before the lung. So you are still giving that patient therapy when you're at 21%. That's important to understand. And each incremental change you make, you need to give the patient between 15 and 30 minutes per titration step. Now, we do it a little bit differently in our practice. We will make a change from, let's say, we're start to wean, we're at 100%. We'll go to, maybe they're doing really well, so we'll go to 80%. So that's a 20% drop, right? And we'll look at it and we'll see what happens from there. If that works great, then we're going to come down about 5%. Only we're going to come down probably once every hour or two. Samir, can you maybe shed some light on that? That's how I do it. But of course, we do change practitioners, and sometimes that gets different. But I'm usually about 5% every hour or two. What do you do? What do you say?
I agree. That's about what I do. I don't like to go too fast. I don't feel, especially during the weaning process, that doing it too quickly is going to be beneficial for the patient, or it's going to be, or it's going to help us actually come off. I like to do exactly like you said, about 5% an hour. Sometimes I'll even stretch it out longer. I like to wean slow, Joe. I'm not in any hurry to get them
yeah,
off.
I do too. But it's also important that you're measuring the PaO2.
Oh,
And
yeah,
you can use an SpO2. I don't have any problem with that if it's accurate. It works. And just keep your saturation above whatever floor you've set. The standard is 92% saturation, PaO2 about 70. So
yeah.
that's your standard. But you may feel different. You may say 80. Your intensivist may say 80. I'm happy with 89%. That's where this patient's going to be, and I'm happy with that. So you really don't have to come down. If you come down from 100 to 80%, and your SpO2 goes from 100% to 99%, well, that's a good sign. And
Oh,
then you
yeah.
can kind of sit there for an hour or two and say, okay, well, I'm at 80%. Let me see what happens if I go to 75. You go to 75, you don't see any change, and then you go to 70, and you see it. Maybe it does change a little bit. If it drops down all of a sudden to 96%. Well, if it makes a big change, or 94%, you're still above 92. But I would stop weaning at that point. I wouldn't continue. And I would say, hey, let's get a gas. Let's confirm all of these numbers. Let's see anything else that might be happening, because we don't know what the CO2 is doing right now, and so forth. And is this number even real? So, you do a gas to confirm all of that. And it may be you just have to sit there for several hours to a day. Because if you go from 80 to 70, and your SpO2 falls from 98% to 94%, trying to go down any more than that is inherently, I just think it's going to fail.
Yeah.
So you can't be always in a hurry as far as that's concerned.
No. I think
All
I
right,
like
fair
I like
enough.
I like the way you illustrated the fact that when you see that big drop, that you do have to pause, because it's so common. You see it a lot, right? Like, I mean, especially on patients where they're really trying to push us to get this patient off a little earlier than we think they're ready to come off, like, for instance, these patients where you are seeing that abdominal breathing type of stuff that you were describing earlier, and the intensivist still wants to try to see it, come see us come down, push us to come down, and we just kind of know that the patient's not ready, and they won't do it unless we show them data, right? Like, until we see that drop in saturation from the pulse ox, which, again, like you stated, is not always very accurate.
But it
we
could
need
be,
to
yeah, yeah.
do that blood gas. You know, we need to show them that, oh well, your PO2 is 80, so there's that. Like,
Right. And that's at 70% or
right,
75%. Coming down another 5% because just you want to, it's going to make you feel better, is going to put us at risk of going below the
exactly,
level we've determined we don't want to go below.
right.
Now they can still overrule you, and you just do what you got to do. But nevertheless, okay. So down with the sweep, that's also very interesting. Is you have to take into consideration that when you start decreasing that sweep, your PCO2 is going to go up.
Yes.
These patients have to be able to ventilate enough to blow that CO2 off. Now, if you have a patient who you believe is going to live in a hypercapnic state, their lungs are severely damaged, probably not going to get a whole lot better, and they're going to likely want to be around 55 to 60 for a PCO2. You better make sure that they have metabolically compensated for that. So if you're going to go the route of permissive hypercapnia and you have not permitted that throughout your ECMO run, well, now if you do that, your pH is going to really suck. And so you have to allow for metabolic compensation, which could take days to a couple of weeks, depending on the circumstances, right? But certainly days, and probably 4 to 5 days before you start seeing enough compensation that you can start coming down on that sweep. So you just have to be aware of that. Now, if they're able to ventilate and they can keep their PCO2 within normal parameters, go ahead and turn that sweep down. Let them breathe. Because if you keep blowing off their CO2, they're not going to breathe the way you want them to, and they need to breathe so that they can exercise those normal breathing muscles, if that makes any sense. Okay. Your VV de-escalation, the off-sweep challenge, at some point in time, you will reach a place where you are going to want to stop all support through the ECMO. The VV ECMO, without any gas going into it, I've said this now 3 times, so I guess it'll be the 4th time, is nothing more than a shunt. It's meaningless. All it is a thrombogenic bucket of plastic and some fibers. So that's all it is, okay? So it's not going to have any effect, but you have to turn the sweep to absolute 0. Now, some places say you have to clamp it. Some people say you have to disconnect it. I've heard all kinds of things. You don't have to do any of those things. You have to turn the sweep off. That's all you have to do. If you do those other things, that's fine if you want to do that. I don't care. You want to disconnect it, that's fine. That's your business. Go ahead. Just remember you did it, so if you have to go back up, you don't turn it back on and wonder, well, why is it not going back up again? Oh, because we disconnected it. I mean, that would be silly, but I guess it theoretically could happen. So just, just turn it off. No sweep is no sweep. There's no benefit, no therapeutic benefit whatsoever. But you want to be off for at least 2 to 3 hours, be with a PaO2 of equal to or greater than 60. It's a saturation somewhere in the 92%. Under either reasonable ventilator settings or the patient breathing on their own with just some level of supplemental oxygen that they're breathing, going back to those previous parameters that I showed you, to say, yeah, we're pretty comfortable. This patient could go ahead and come off and get them off of the ECMO. And that's sometimes that liberation itself, and they're breathing on their own, actually improves their outlook so much, and they do really, really well. They almost do better getting them off the doggone ECMO. Now, that can go the opposite direction too, but that's what it is, right? You do the best you can, knowing full well you may have to reintroduce the ECMO if the patient decides to crash. So there is a decannulation pre-procedural checklist. And one of those things, of course, is going to include the ability to reinitiate. And you can see those here. Decannulation, post-procedural, you want surveillance, very close surveillance, and DVT prophylaxis. And of course, if you have to close anything, usually VV ECMO, you rarely have any significant bleeding. Pitfalls to overreacting to oxygenation versus mechanics. The oxygenation trap is overreacting to low saturations, 80 to 9% during a weaning challenge, and escalating ventilatory settings to compensate. Sometimes you have to be patient and wait and not overreact. Things happen, but then they correct themselves. So the patient won't die short term with an 80 to 90% saturation. So just think about it for a minute. Physiological truth, mixed venous saturations under VV ECMO naturally drop below 100%. Systemic oxygenation delivery depends strictly on tissue perfusion and hemoglobin, not saturation percentage, which makes sense. So long as you have a good cardiac output and sufficient hemoglobin, then your DO2 will be just fine, despite having what you think is too low of a saturation. You have to take the total oxygen content times the cardiac output to really determine whether or not you need to intervene here or not. Escalating the PEEP and FiO2 and plateau pressures during trials cause secondary ventilatory induced injury and negates the benefit of lung rest. So you just want to avoid that. The pitfalls of conversion, flow and conversion hazards, expecting circuit adjustments to stabilize systemic blood pressure. Physiological truth, increasing VV ECMO blood flow does not improve arterial blood pressure. As everyone knows, systemic hypotension is driven by vasoplegia and or hemorrhage or other things. Converting VV ECMO to VA ECMO for transient desaturations, this incurs severe arterial risk, stroke, limb ischemia, and there is no systemic benefit. And it's just published. People have done this, they do this, but you don't want to do that without first giving it some time. And I know that's sometimes hard to do because you think your patient's dying and they're failing, but sometimes you just got to be patient. VA ECMO and ECPR weaning is a little different, and something I'm going to talk about here is let's see if it's in here. Yes, the Delphi consensus. I'm going to get to that towards the end. This is very important, I think very beneficial for this particular topic. But you look at your initial target, mean arterial pressure greater than 65 is recommended as a baseline. Vasoactive stewardship. In other words, you've got to know what drugs you're on and how much you're on. Prioritize increasing ECMO flows over excessive doses of vasopressors, fluids, or inotropy, because that's going to really mask where you are, and you don't want that. You would rather use ECMO flow and let the patient become hemodynamically stable through homeostatic processes. Afterload limit, consider afterload reduction if mean arterial pressure is greater than 80 with signs of LV distension, and review targets daily while maintaining cerebral perfusion. Your pulse pressure, maintain a pulse pressure of equal to or greater than 10 as a sign of baseline cardiac recovery. That can be masked if you have an Impella in, you have a 5.0 Impella in, or you have even a CP in. You know, you may have to turn that power down a little bit in order for you to see the LV ejecting. Low pulse pressure of less than 5 despite optimization should prompt immediate consideration of LV unloading. That would be either the tandem or the transeptal approach for drainage, or ECPella, which is much more common these days. And then inotropes are an important adjunct to support contractility and keep the aortic valve opening. You do not want to get a thrombosed LV. Weaning titration, titrate flows down only if lactate clearance and end organ markers remain completely adequate. We need to measure lactates more frequently. We don't do it as much as I would like, but I think they should be run at least once a day. You want combined serial lactates. There it says daily echocardiography, continuous invasive arterial lines, and other clinical signs. And then use pulmonary artery catheters. They're very useful. So I am an advocate of using swans because you can measure PAPI and a variety of other things, though they're not mandatory. Keeping your aortic valve opening, obviously it's super important. I don't even have to say a whole lot about that. And then surveillance and stasis risk, direct visual tracking of AV movement, aortic valve movement is mandatory during weaning. Visible smoke, spontaneous echo contrast, we've seen that with poor LV function or the aortic root, should prompt immediate optimization of LV ejection and anticoagulation. If you see smoke in the aortic root or the LV, you got a problem with your echo. Balance, weaning flow reductions to stimulate AV opening must be balanced against maintaining cerebral and systemic perfusion, and cerebral danger over reduction of pump flow can trigger severe cerebral hypoxemia. So very important. Active venting triggers, persistent complete AV closure. Worse enough, if you have a mechanical aortic valve, you're going to have to go transseptal. Worsening echocardiographic LV dilatation is intractable worsening pulmonary edema, spontaneous echo contrast in the root LV, which is the smoke we talked about. It's not actually contrast, right? Low pulse pressure, less than 5. I think you could just say the pulse pressure of less than 5 and leave all the rest of it out, because if you have a pulse pressure of less than 5, that's a problem. You want to decompress the LV immediately to protect myocardial wall tension and prevent irreversible stasis. So keep in mind, as you dilate that LV and put it under pressure, your LV chamber is under pressure. Its ability to perfuse the myocardium normally is obstructed because of your natural flow patterns of your vascular anatomy, right? So that's a real problem. Your microcirculation of your LV or your heart in general will not be being perfused. It will take the path of least resistance. Prophylactic LV venting or unloading is not routinely required in all post-ECPR patients. Though it seems to be very common, because I think they go Impella first and then Impella is not sufficient, so then they go to ECMO. And I have to say this, I both like and dislike Impella. I like Impella because I think under certain circumstances it's extremely useful and a really good tool. I dislike it because I hear these reps say, "Oh, you don't need to do ECMO. You can do Impella. You should just do Impella in this case." And we see that a lot, where we're putting Impella in first and it's failing, and then we're going to, because the right heart's going to fail, and then we're going to either go to bipella, RP and systemic, or we're going to go to ECMO. Whereas I think I just think that sometimes they are over aggressive with their device being the panacea, the one size fits all, and it just isn't. So I like them as far as I think the device has utility. I think it's overused and sometimes misused because their salespeople or their clinical reps are just too terribly aggressive. But you can use a balloon pump. The problem with a balloon pump is if you are peripherally cannulated and you're flowing retrograde up the femoral artery and inflating the balloon, then you are diverting your flow from the superior portion of your body to the inferior portion of your body. So your kidneys are going to love you, your liver's going to love you, your legs are going to love you. Your mesentery is probably going to love you, but your brain and your heart aren't going to like you very much at all. So keep that in mind. So balloon pump with central cannulation is perfect. I have no problem with that at all. But with peripheral femoral cannulation, you have to be cautious. And usually what we'll do is it does help some unloading with deflates, but you're going to have to use about a 50%. Somewhere in that range, 40 to 60%, but certainly no more than 60% inflation on it. So you'll have to reduce the amount of gas in it so it is not fully obstructive. Let's see, and then unloading interventions must maintain net forward systemic perfusion. I think that's kind of what I just said, only I said it the long way, if you don't mind. Standard anticoagulation, VA ECMO is far more difficult to manage than is VV ECMO. We have done VA ECMO with very minimal to no anticoagulation, with only antiplatelet medications like Kengalore, and have had good results. But we just recently had a situation where we were not wanting to use a lot of anticoagulation, and we were cutting it really tight, and we ended up with thrombus in the entrance of the oxygenator.
Yes.
And then the next week we had thrombus in that same patient at the inlet of the centrifugal pump.
Yep.
And and it just really was challenging. This was a more complex cannulation, and a lot of flow going a lot of different places, and ultimately we had to go up on the anticoagulation because this was going to continue to be a problem. And you really want to avoid getting thrombus in your circuit, but in this particular case we definitely had it on 2 occasions, and then we made a change, but we probably should have done that after the first one. Flow is very important. It's very hard to wean VA ECMO with very low anticoagulation. You really want to increase the anticoagulation at that point, because you're going to have a lot of risk. Surveillance, once you've taken them off, perform routine head to pelvis CT, imaging post-resuscitation, obviously useful to identify cardiac arrest etiology or injuries from CPR. Avoid early neuroprognostication on CT unless it is catastrophic, because especially post-arrest. Distal perfusion cannulas, you definitely want to use those. NIRS is very, very good for both the cerebral and for the periphery. I really believe in that. Echocardiography, performed within 24 hours of admission. Conduct ongoing daily assessments to track myocardial recovery and monitor pericardial effusions closely, as tamponade signs differ when you have the patient on ECMO. So you're not going to have the normal trilogy, right? Consider increased nurse to patient ratios in the first 24 hours. You don't want to pay a nurse having 3 patients with one of them being an ECMO. I think that's absurd. I think ECMO should be 1-to-1. That is my true belief. Pressure area care and patient turning are required, so you want to avoid obviously pressure wounds and skin breakdown and so forth, and that's something I think we do really, really, really well. I'm amazed that we have had a patient now on ECMO for about 45 days, maybe even longer, and there is no tissue breakdown anywhere on that patient. And that is a testament to the care given by the nurses at that institution, and I'm exceedingly proud to be associated with them. I think I can say where it is. I don't think there's an issue with that, but well, maybe I shouldn't, because I said
you
there
shouldn't.
was ECMO. Yeah, but it's a hospital. But I'm I'm very gratified to be associated with that institution. Staffing and position care, consider increased nurse to patient ratios in the first 24 hours. Pressure, we talked about that. So what are you going to do? Standardized weaning studies, or are you going to do bridge to destination and palliation? So if the plan is we're getting this patient destination, we're sending them somewhere else to be cared for, well, at that point in time, listen, maximum support, and keep every organ system working as best you can. Wake them up, assess their neurologic status, know whether or not this is a good candidate for some other therapeutic modality, whether it be transplant or durable VAD, and in my opinion, maximum support. That's what I think. If they're not going to make it, it's really hard, but you've got to deal with the family and deal with end-of-life decisions. And that, after a very long ECMO run where people have been praying for weeks, is agonizingly painful. So that's how I feel about that. If you're going to decannulate them, then have protocolized pathways. Define your strategy post-decannulation backup in advance of actual cannula removal. So are you ready to reinitiate if that's what the plan will be? what your reinitiation criteria would be if that's what you're going to do. And then fail safe guard, standardized weaning paths, minimize rate of actual recannulation. In other words, don't decannulate if there's any question in your mind that they're going to be able to sustain on their own. That's bottom line. I think that's almost to the point of being common sense. Here's a nice, I won't go through it all, but ECLS weaning failure decision pathways for VV versus VA support. And I'll allow you to look through these on your own. I don't have to go through them all independently, but you can take a copy of this, a screenshot of it, or whatever you want. And then we'll move into the Delphi, which is here post-ECPR care, and this is an expert consensus guideline. They went through 3 rounds, and round 1 was 102 statements, reduced down to 84 statements, reduced down to 24 statements, with 64% consensus reached. And for your ECMO, you map of great, this is for ECPR, so this is VA, right? Mean arterial greater equal to or greater than 65, lung protective ventilation strategies, target SpO2 of 94 to 98%, and maintain normal PaCO2 levels, avoiding rapid drop in carbon dioxide. And that's something that's also very important. It's something I learned only in the past few years, that there is a correlation. It is not, and this is important, it's a correlation. It's not been proved that this causes, that's an actual cause and effect, but it certainly is very suggestive that if you take a patient who is acutely hypercarbic from an arrest, and or a CPR circumstance event, and you put them on ECMO and you drop their PCO2 too rapidly, it is suggestive of increased risk of cerebral hemorrhage. And so that's something I've just recently learned in the past few years. So be very careful of that. Immediate cardiac catheterization should be performed to clear non-cardiac cause for the arrest. If it's not cardiac, what is it? So you want to do that as quickly as you can. Delay neuroprognostication for 72 hours. It's not, give a patient who has had CPR and crashed on ECMO at least a few days to kind of recover their consciousness. They've been given a lot of medications, a lot of things can be masked, and you really can't say with any sense of certainty whether or not this patient has had a stroke, unless their pupils are blown and there's some obvious signs. But you could do a CT and determine whether or not there's been a massive cerebral hemorrhage or not, or something like that, or severe anoxic brain injury. But by and large, it's going to be more subtle. Even unequal pupils may not tell a full story. That sometimes is just benign. So you have to be very careful about that. Comprehensive complications are able to perform routine head to pelvis CT imaging and daily echocardiography to identify trauma or mechanical issues, and standard follow-up. This is very important. We should be following up on all survivors for at least 6 months post-discharge from the hospital. This is all part of this Delphi consensus process, and it's something that I think that should be adopted universally within centers that are doing ECMO. And I asked this question, why?
You were coming to this.
Why? Well, it's really interesting because I know what you thought. But if you really look at the picture, neither of these gentlemen's hands are here. This is this lady's own arms with her hands here. They're actually reaching behind her back, both of them. But it still begs the question, why? Nowhere does it suggest you should decrease the FiO2 to the oxygenator for weaning VA ECMO. I have seen this now several times. It's disturbing. It makes absolutely no sense whatsoever. And if someone that you work with, love, or whatever, suggests that you do this, please ask them to show you any published data that suggests that is a good idea. It is a horrible idea and shouldn't be done.
On paper, it seems like a horrible idea. I mean,
it is a horrible idea.
It just seems like one.
The question is why? Just why?
Yeah.
Okay. Any questions, comments, concerns? I'm here.
Let's see.
And my references.
I'll tell you.
Okay. I can turn that off.
Not seeing anything so far.
Good. I've answered everyone's questions, or they've left.
Or they left. There you go.
Or they left. Or they just said,
we got a couple people here.
Joe's crazy.
Joe is crazy.
Joe is crazy. It's true. What do we got?
Somebody saying thank you. Very informative. And he's
You're
crazy.
welcome. And did he say I was crazy too?
No, I'm saying that.
Who said it?
Of course.
Oh,
no, me. Very, with exclamation points.
And that reminds me. I don't know if he's on or not, but I sent Harsh Patel. Took me a while to get it to him. Harsh Patel, if he's on here, I sent him his PerfWeb cups and wine goblet.
Did you?
Yeah, I did.
Okay.
And I haven't gotten a word from him thanking me for it. And it was all the way up in Canada. And it cost me a freaking fortune to ship it to him because of the freaking tariffs.
You see that? Oh, those tariffs.
Exactly. Now, everyone, we're in for a real treat.
Yep.
Samir Patel will be battling.
I will be battling.
Lindsay Roberts and Daphne Rodriguez.
Yep.
And in our Perfusion in Jeopardy. This is our second installment. Yeah. And since Samir was the reigning champion where he cheated and
cheated.
Beat me.
Hold on.
Cheated and beat me. Yes, cheated and beat me. You're going to get
cheated
a
by
rare
being
treat.
Smarter?
You're going to get a rare treat. You're going to get a rare treat and really appreciate this show. So I'll be here at the end for all y'all. If you have any comments or anything like that, or to say goodbye to you, Samir, you're welcome to stay with us. Of course, you're going to be on the show, but you decide what you want to do, and we'll go from there. So, David Sullivan, if you would please start the program.
From the ManyWeb Studios, this is Perfusion in Jeopardy with your host, Mindy Navarrete.
Hello, everyone, and welcome to yet another episode of Perfusion in Jeopardy. We're so glad that you came, and hopefully you're going to learn a little something and have some fun. First, we're going to meet our contestants. We have Daphne Rodriguez. She is a perfusionist here in the Houston area. Next, we have Samir Patel, also a perfusionist in this area. And last but not least, we have Lindsay Roberts, a perfusionist in this area.
No, you don't say.
Okay. I am your host, Mindy Navarrete, and we are going to get right to the game. Our first Jeopardy, we are going to have the categories, which are Don't Go Clotting My Heart, Name That Formula, I Want to Suck Your Blood, The Prime Suspects, Balloons, Beaches, and Blood Pressure, Pump and Suck for the Almighty Buck. Okay, we are going to start with Samir because he is our reigning champion.
All right.
Samir, you pick.
Okay, Pump and Suck for 1,000.
Oh, going big.
Knew it. I guess 1,000.
He is going to bet 1,000 right off the bat. Okay, Samir, according to Henry's law, as blood temperature drops during hypothermic bypass, the solubility of gases in plasma behaves in this manner.
The solubility increases. What is the solubility increases?
That is correct. Great job. Samir, control the board.
Pump and suck for the almighty buck for 800.
These types of pumps are considered completely load dependent. Samir,
What are roller pumps?
that is incorrect.
Oh, godly.
Lindsay,
What is centrifugal pumps?
Yes.
what is excuse me?
Centrifugal pumps?
That is correct. Good job, Lindsay. You now have control of the board.
Ooh. I guess let's keep same category, pump and suck for 600.
Okay. Every 7 degrees Celsius that the body temperature is reduced decreases the oxygen consumption by roughly this percentage. Samir,
What is 50%?
that is correct. Control of the board, Samir.
Let's go with balloons, beaches, and blood pressure for 1,000.
If the balloon is positioned too far inferiorly, the balloon risks occluding blood flow to these critical arteries. Daphne,
The renal mesenteric arteries,
excuse me,
inferior.
Answer the
Or
question.
Renal. What is renal mesenteric arteries?
that is correct.
There you go.
Good job. Daphne, you now have control.
Let's do balloon, beaches, and blood pressure for 200.
Inflation of the intra-aortic balloon must occur precisely at this physiological landmark on the arterial pressure tracing. Samir,
What
is it
the
Samir or
dichrotic
Lindsay?
notch?
Excuse me, was it Samir or Lindsay? Which was
It was
Samir? Okay,
What is the dichrotic notch?
that is correct. Samir?
Let's go with balloons, beaches, and blood pressure for 800.
On a properly timed 1 to 2 assist waveform, the assisted end diastolic pressure should be lower than the unassisted end diastolic pressure, and the assisted systolic peak should be lower than this landmark. Nobody?
It's a long question.
You lost me.
No, she didn't meet the timer.
Unassisted
What
peak,
is the
okay.
unassisted systolic peak?
Yeah, makes sense. You lost me halfway in that one.
How do I get back to the board? Okay,
There's a lot of words.
Samir, you still have control of the board.
Okay, let's go with the prime suspects for 1,000.
This size tubing holds 1.05 milliliters per inch of volume. Daphne,
What is quarter tubing?
what is,
Quarter? No.
that is incorrect, sorry. Lindsay,
What is 3/32nd tubing?
sorry, that is also incorrect. Samir, would you like to take a shot at it?
Absolutely not. I know it's very small tubing.
What is 3/8
it's per
inch
inch.
Per
tubing?
inch, yeah, you're right. It's not a foot.
Okay, Samir, you still have control of the board.
I'll take the prime suspects for 800.
This size tubing only holds 3.3 milliliters of volume per foot. Daphne,
What is half-inch tubing?
that is incorrect. Lindsay,
Just guess.
What is 1/16th tubing?
that is also incorrect.
Oh my gosh.
Samir is not going to try.
Very small tubing,
What
yes.
is 3/16
Very, very
inch
small
tubing?
tubing.
Samir knows better than to answer.
Okay,
Not on
Samir,
those.
back to the
We're
board.
both negative.
Let's get out of that category. Let's go with I want to suck your blood for
Maybe
1,000.
let's get it over with.
This multi-step laboratory process physically combines the patient's serum with the donor's red blood cells to check for agglutinations before the blood is issued. Daphne,
What is a Titan screen?
that is not correct.
It's on the
Anyone else? Oh, no. Anyone? The answer is what is a cross match, which is different than,
You were there.
Very
It's
close, but
wrong-
different.
Wrong wording. Let's do the same category for 800. I want to suck your blood for 800.
this type of plasma is considered the universal donor. Samir,
What is O? Oh, sorry, AB. That's right. What is
yeah,
AB?
okay. Well, that is
It's
incorrect,
incorrect.
but you gave the answer.
I did.
Yeah.
What is AB plasma? Okay, Samir,
Let's do, name that formula for 1,000.
this equation, 6.1
God.
plus log bicarb times 0.03 times PaCO2 is used to calculate this. You all know this. Lindsay,
What is base excess?
that is incorrect. Daphne,
DO2, so delivery of oxygen.
that is incorrect also. Samir, again,
Absolutely not.
okay, we have the chicken.
I know.
What is arterial pH?
Known that. Anytime there's a log,
All right,
it's
Samir,
pH.
back to the board.
Yeah, you're right.
I knew that, but I just didn't want to say it because I wasn't sure. Okay, let me say, name that formula for 800.
Some of these are wordy, some of them.
Cardiac output times hemoglobin times SaO2 times 1.34 plus PaO2 times 0.003. This formula is used to calculate this. Daphne.
What is DO2?
Very good.
You just a question off.
Daphne, control the board.
Oh, let's do the prime suspects for 200.
The size of tubing holds approximately 5.8 milliliters of prime volume per foot.
What is half-inch tubing?
That is incorrect. I'm sorry. Anyone else?
40 ml for half-inch tubing.
Anyone?
I don't want to. I don't want to guess now.
The correct answer is what is a quarter-inch tubing?
I was going to say something small.
Right.
Okay, Daphne, you have control of the board.
Go ahead.
Oh, me?
Yep.
Don't go clotting my heart for 200.
This medication can rapidly reverse warfarin anticoagulation. Samir,
What is vitamin K?
that is correct. Good job, Samir. Back to the board.
Let's go. Don't go clotting my heart for 1,000.
Double.
Let's do 1,000.
Okay, Samir is going to wage 1,000. Sea light is also known as this. Remember, you have 30 seconds to answer.
I don't know. You can not,
not
do the
know?
30 seconds. Yeah, I don't know.
What is diatomaceous earth?
I would never have guessed that.
Becky would know that because Juan said it all the time. Okay, back to the board. Samir has control, correct?
Don't go clotting my heart for 800.
This activator is used in the Hemocron high-range cartridges. Lindsay,
What is kaolin?
that is correct. Good job, Lindsay.
That was good.
Lindsay, you have control.
Let's do the prime suspects for 400.
The size of tubing holds approximately 12.6 milliliters of prime volume per foot. Samir,
What is quarter? No, sorry. What is? Yeah, quarter inch.
know.
your time is up, sorry. Anybody else?
No.
No?
No.
What is
3.
3/8 inch tubing?
See, I learned it as
Yeah.
15.
I thought that's 20 a foot.
No.
15
Just
and then
saying.
30, it like doubles.
You're thinking
okay.
of half inch.
Yeah.
Half is 40.
No, it's not.
It's not.
No.
Okay. You sure?
You may look it up, and in the break, we will go over that. Okay, control the board. Who had this one? So,
No,
Lindsay.
Lindsay did,
Lindsay,
yeah.
you have control of the board.
Let's get that category over with. Prime suspects for 600.
Half-inch tubing holds
Now
this
that we
much
just talked
volume
about it.
per foot.
30.
Daphne.
What is 30?
That is incorrect.
32?
Anyone else?
No,
No
feel
one's
like you're
going to take
looking
a
for-
shot at it? What is 22.3 milliliters? Yes, that's why I
believe that
say
for a
it's
second.
not worth it to wrap your arterial line. Okay, Lindsay, control the board.
Okay. Name that formula 200.
The square root of centimeters times kilograms divided by 3,600 is the formula for. Lindsay,
What is BSA?
good job. That is correct. Lindsay, control the board.
Name that formula 400.
When converting from millimeters to French, 1 millimeter equals this many French units. Samir,
What is 3?
correct. Samir, control the board.
Let's go with Don't Go Clouding My Heart for 600.
This drug is about 6 to 10 times more potent than Amicar. Samir,
What is TSA?
that is correct. Samir,
Don't Go Clouding My Heart for 400.
this protein enhances the activity of heparin by inhibiting thrombin and factor 10A.
Oh, I don't know which one of the two it is. Okay, I'm gonna let it go. It's either C or S, but I'm just
Your
saying.
time is up. I'm sorry.
I just don't know which one of the two.
Anyone else?
No.
Did you didn't
No, I
actually
didn't
impress?
answer it. No,
Okay.
no, it was-
The
time was up.
answer is
Oh.
antithrombin 3.
It's just worded weird.
Yeah.
It's worded like the boards.
Yeah, it really is. So me,
Yes.
I want to suck your blood for 600.
The presence of this specific inherited surface protein determines whether a blood type is classified as positive or negative. Samir,
What is the RH factor protein?
that is correct.
Let's go with I want to suck your blood for 400.
A person with this blood type is considered to be the universal recipient. Samir,
What is AB?
AB,
Negative.
that is incorrect.
No.
Anyone else? Daphne,
What is AB positive?
Yes.
that is correct. Daphne, you have control of the board.
I want to suck your blood for 200.
This type of blood is considered to be the universal donor. Daphne,
What is O neg?
that is correct. Good job, Daphne. Still control.
Let's do pump and suck for the almighty buck for 200.
Love that category name.
In cc's per kilogram per hour, this is considered adequate urine output for a patient on bypass. Samir,
What is 1 cc per kg per hour?
very good, correct. Samir,
Let's finish that category out for 400. Pump and suck for the almighty buck.
these types of pumps are positive displacement pumps. Lindsay,
What is a roller pump?
that is correct. Good job. Lindsay,
Let's do balloons, beaches, and blood pressure for 600.
if inflation occurs prior to the dicrotic notch, it increases afterload, forces the aortic valve to close prematurely, and leads to the dangerous physiological consequence.
I don't know the name for.
Nobody? Increased left ventricular workload.
Yeah.
That's kind of a hard thinking one. Okay, we are now at the end of that round. Our time has run up. Before we go to break, we're going to go over our scores. Daphne, right now you're at negative 2,200. There is plenty of time to come back. Samir, you're at 400. Lindsay, you're at negative 600.
Okay.
We will be right back after this short break, and we will have more Jeopardy for you. All right. All right, welcome everybody. We are back for our Perfusion in Jeopardy. But before we get to this next round, I want to meet our contestants and get to know a little bit about them. Okay, Daphne, I understand that you really enjoy baking. And what do you bake exactly?
I do. I'm really into sourdough right now. So I like to believe that if I throw sourdough into anything, it makes it healthy. So then the calories don't count.
Oh, I see. Kind of like if you eat something past a certain time, calories don't count.
Just,
Got it. I agree with that too.
healthy.
Are you just doing this for yourself, or do you sell it, or is it just a hobby?
I like to bake it for friends, or I've made you guys, some sourdough, like jalapeno cheddar little loaf.
Oh, that was so good.
It's weird. I've never had this. I don't know where she's given it.
It was really
One
good.
of the crawfish boils, right?
Yeah, it was,
Oh,
it
I
was so
wasn't
good.
there.
Oh,
I'll be expecting some next
Yeah,
week.
I'll make you some cookies, because then the calories don't count.
Great. Samir,
Mhm.
I hear you might have an addition to your family.
I do. It was quite the surprise, but yes. we'll
And
be
this is
having-
going to be number...
Number 3. Yeah, number 3. Just found out last week. It was.
Wow. What are the ages of your other two?
One of them just turned a year, and the other one is about to turn 8.
Okay, so I guess we're going to have two pretty close together.
Yeah,
Yeah.
two pretty close. Yeah.
Wow. Well, good luck with that.
Yeah, it's gonna be a handful.
Lindsay, now what's a little interesting tidbit about you that we can talk about?
I've just recently started learning how to juggle. I'm not good at it yet,
Juggling.
but I'm pretty determined.
Okay, and how are you learning this?
I met a friend at a bookshop, and all of a sudden she was like, "Oh, by the way, I juggle, and I meet up with these other people that juggle, and we can come teach you."
What do you juggle exactly?
Just
I
like
always think of
little
bowling
juggling
ball
balls. It's just little like sand-filled balls or something.
Interesting. Maybe
They
that
do
will-
more advanced things. They're really good at it.
And do they do more than 3 balls?
Yes.
Wow.
And they like pass to each other. They do the pins. One of them can be on like a unicycle while he does it.
Oh my God.
Yeah.
Okay.
It's been very interesting.
Straight up circus
So at
stuff.
our next
Wow.
party, we're going to expect Lindsay to be
No.
juggling, food from Daphne, and you're going to have a lot of
Yeah.
kids running around
Yes.
We'll be
enjoying
the
this.
entertainment
Yes, I might not even be
entertainment for
there.
your.
Okay, great. We are now going to get back to Double Jeopardy. These are our categories. Drug lords, it's all in the vein of science. Pump squared, the root of the matter, name that cardioplegia,
Okay.
not the E word. Okay, control of the board from our last round. Oops, set up. Was that Lindsay?
I mean, I guess my name's
I was
highlighted,
there.
so
I like Lindsay.
I don't know.
Lindsay's
Okay.
good.
We're going to go with Lindsay. Lindsay, you have control of the board.
Let's go. Pump squared 400.
This complication of VA ECMO is reduced by adding an impella. Daphne,
What is LV unloading?
what is?
LV unloading?
That is correct. It's for left ventricular distension, so yes. Daphne,
Let's do, name that cardioplegia for 400.
the coronary sinus pressure is often measured when delivering cardioplegia by this method. Samir,
What is retrograde?
correct. Samir, control the board.
All right, let's do pump squared for 2,000.
Pump squared 2000. This was the year that Aviomed received FDA clearance for the Impella 2.5. Oh, Daphne.
Wow. Nice.
Total guess, the year 2005.
Oh, so close, so close. That is not correct. Anyone else? Okay, the answer is 2008.
Ooh, you were
Very
close.
close though, Daphne.
Yeah.
Daphne, you still have control of the board.
Let's do not the E word for 400.
This physiological condition occurs when the arterial oxygen saturation in the right radial artery falls despite adequate ECMO flow and oxygenator function.
Oh, good.
Daphne,
What is your circulation?
that is not what I'm looking for. Sorry. Anyone else? Samir?
What is north-south syndrome?
Yes, north-south syndrome or Harlequin's.
Yes, yes.
Good job. Samir, control the board.
Let's go with the root of the matter for 2000.
A patient presenting with severe aortic insufficiency will exhibit this classic arterial waveform feature on the A line. Daphne,
What is dampened arterial waveform? I don't know.
that is not correct. I'm sorry. Anyone else? No? Correct answer, what is a wide pulse pressure? Or the hammer bounding or whatever you would say. Okay, Daphne, you still have control.
Let's do drug lords for 400.
This toxic byproduct can accumulate with prolonged nitro use. Samir,
What is cyanide?
that is correct. Samir,
Let's go drug lords for 2000.
this granulocyte releases heparin. No one's going to give it a shot. The correct answer is basophil. Make sure Samir's scoring good. Huh? Samir, still control.
Yeah, let's go with drug lords for 1600.
The molecule size of unfractionated heparin.
Oh, gosh.
Nobody?
These are hard.
It's double jeopardy.
It's double jeopardy.
What is 3 to 30,000 Daltons? Average around 15,000.
Okay.
Okay, Samir.
To know.
Let's go with it's all in the vein of science for 2000.
During cardiopulmonary bypass, these cells may become activated and contribute to postoperative lung injury. Samir,
What is complement?
I understand. No, that's not what we're
No.
looking for.
But that's what it is.
Very close, very close.
Okay.
Anybody? The answer, what are neutrophils?
The complement activates the
It does,
neutrophils.
it does, I know, I understand, I
You're the
know.
wrong place in the chain.
You're like.
It's on the same, but on the boards, that's not.
Yeah. Okay.
Samir,
It's all in the vein of science for 1600.
contact between blood and artificial surfaces of the bypass circuit activates this plasma protein system involved in inflammation. Samir,
What is complement?
yes,
Which
that
then
is correct.
activates neutrophils.
That is correct. Okay, Samir,
Okay. I knew it was going to come eventually. Let's go with it's all in the vein of science for 1200.
this inflammatory mediator causes vasodilation and increased vascular permeability during the inflammatory response. Samir,
What is histamine?
correct. Good job, Samir. You have
Let's
control.
go with pump squared for 1600.
This type of pump mechanism is used in the impella. Samir,
What is the impeller pump system?
that is not correct.
That's what we call it.
Sorry, anybody else? Nobody? The answer is, what is the axial
Nope,
flow
not what I
pump?
would have said.
Again, they call it the impeller pump system.
Well, that's like saying, what is a roller head? It's a roller head. I mean,
okay.
Samir,
Name that cardioplegia for 2000.
this early potassium cardioplegia developed in the 1950s was largely abandoned because it caused myocardial damage known as stone heart. Daphne,
Was St. Thomas cardioplegia?
no, we still use St. Thomas today, sorry.
Just a,
It's one I've never heard of, just so you know. Anybody else?
No.
The answer is Melrose
Melrose.
cardioplegia. I've actually never
Guys
even
at
heard of it.
Melrose, they had it all wrong.
Okay, back to the board.
Not the E word for 2000.
For patients who develop HIT while on ECMO, this specific direct thrombin inhibitor is an excellent alternative choice. Samir,
What is bivalrudin?
that is correct. Samir,
Let's go with not the E word for 1600.
This is the year that ELSO was founded. Yeah, no one's going to take a shot at that.
takers on this one.
What is
Oh, I
1989?
got that so wrong.
Forget that. I lose points.
Okay,
for
Samir.
Name that cardioplegia for 1600.
This cardioplegia solution, also known as HTK, allows long arrest times with a single large dose. Daphne,
What is custodial cardioplegia?
good job. That is correct. Daphne, you have control.
Root of the matter for 400.
This is the normal aortic valve area. Daphne,
Area?
yeah, what is the normal area of a valve?
Less than 5.
Oh,
I'm trying
Our
to think
time
of
is
like
up,
things.
but-
Oh, okay. Okay.
I'm sorry. Anyone else? Normal valve area? No?
No.
What is 3 to 4 centimeters
should've
squared?
guessed.
There you go. Less
I would've
than
said-
5.
Well,
yeah.
I should have guessed. I would have said 3.
She was on it, man.
Okay, back to the board.
Oh, is it me?
Yes.
Oh,
Yeah.
it's all in the vein of science for 400.
One hemoglobin molecule combines with this many molecules of oxygen. Daphne,
2?
that is incorrect. Anyone else?
Yeah.
Lindsay,
1 is 4.
correct. Good job, Lindsay.
Good job.
You have control of the board.
Okay. Which category was that?
All in the vein of science.
Okay. Let's do all in the vein of science 800.
This type of white blood cell makes up about 60% of circulating leukocytes and is the first responder to infection. Lindsay,
What is neutrophil?
correct. Good job, Lindsay. Control the board.
Let's do pump squared 800.
This can occur if the impella migrates too far into the LV. No one? What is ventricular suction events? Lindsay, still control.
Okay. Let's do pump squared 1200.
This is the most common complication of impella support due to shear stress from the pump. Lindsay.
What is hemolysis?
Correct. Good job, Lindsay. You have control of the board.
Let's do name that cardioplegia 800.
This cardioplegia solution, named after a cardiac surgeon, uses a blood to crystalloid mixture and often has to be re-administered every 20 minutes. Daphne.
Is this Buckberg solution?
Good job. That is correct. Daphne, you have control.
Let's do not the E word for 800.
This is the most common cause of hemolysis during ECMO. The correct answer is excessive pump speed or high shear stress.
Okay.
Daphne, you still have control.
Let's do not the E word for 1200.
This lab marker is commonly used to detect hemolysis in ECMO patients. Samir,
What is plasma-free hemoglobin?
that is correct. Good job. Samir, control.
Let's do the root of the matter for 800.
Bioprosthetic valves are commonly manufactured using tissue harvested from these two animals. Daphne,
Peas in cows.
what is cows and
Pigs.
pigs? That is correct. Good job. Daphne, control.
Sorry, I forget that we have to answer with the question. Name that cardioplegia for 1200.
This type of cardioplegia uses 4 parts of crystalloid to 1 part blood. It adds mag to prevent the cells from getting overloaded with calcium. Lindsay,
What is Del Nido?
correct. Good job. Lindsay, control the board.
Let's do root of the matter for 1200.
After receiving a mechanical valve, patients must be put on this type of oral anticoagulation for life. Samir,
What is warfarin?
correct. Control the board, Samir.
Let's do drug lords for 800.
At low doses, this drug may increase renal perfusion. You are dope. The correct answer is dopamine.
Oh, okay.
You trying to give us a hint?
So let's do drug lords for 1,200.
Gotten all of them.
I did.
Samir, what are you going to bet?
Let's do 800.
Coming a chicken. Protamine neutralizes heparin through this type of interaction.
What is salt combinings?
What is
Salt combining, they combine their salts, they combine. That's what it is.
it's a kind of, I'm going to say incorrect. It is a type of binding. It is ionic binding.
Yeah, okay.
The last question on the board. Root of the matter for 1,600. Audrey Lido. Samir, you have control because
Okay, let's do 500.
with the mitral valve, the normal
knew it was
mitral
gonna
valve
be this.
area is this.
What is 2 to 3 centimeters squared?
That is incorrect. It is
knew
what is
it wasn't
4
gonna be
to
right.
6 centimeters. Good guess. Okay, we are done with our double Jeopardy round, and I'm going to have to say these are hard questions. I mean,
Those weren't hard.
they are hard, and let's say I probably wouldn't have any points. So I think you guys did a great job. We're going to go to break, but before we do, we're going to go over our scores. Daphne has negative 5,800, Samir 3,900, and Lindsay 3,000. We will see you back in a short 2 minutes. Welcome back, everyone, to Perfusion in Jeopardy. We are here for our final round of Jeopardy. Right now, our score is negative 5,800, 3,900, and 3,000. Let's get to our final Jeopardy question.
What's the category?
It didn't say it.
Oh, yeah, God be the perfusion.
This was discovered in 1916 by a medical student, J. McLean. This organic acid was originally isolated from canine liver cells. You have 30 seconds, and please write your answer on your board.
Do we have to write the
Now,
amount?
first do your wager. I am so sorry.
Oh, are we just doing the wager right?
Yes, first
Okay.
write your wager and then your answer.
I feel like I have to. Just to have a chance at.
I know. That was all.
Okay, time is up. Daphne, you can we'll just see if you, okay. We're gonna put in 0 because the rule is you're not supposed to anyway.
Yeah.
It's not even letting me type it in. So it won't because it's,
Yeah.
so,
Because it's.
next player.
Oh, it just
Hey,
shows the
Lindsay,
answer.
what did you wage?
1,000.
$1,000.
Because I have to. If I want a chance at beating you, I have to.
Yeah.
Okay, Lindsay, what is your answer?
Oh, should I have written that too?
Yes, write your answer.
Oh,
Sorry.
Oh, now you know the answer.
I already knew. No, I already knew it. I thought she was saying just put it.
She saw the
That
answer.
is correct.
I guess I should have.
Samir, what is your wager?
I just wager 0. I don't know.
0?
Yep.
And what would your answer have been?
Heparin, but you would
Okay.
have. It wouldn't have been fair.
So our final result.
Swear I knew it before it accidentally showed it.
Yeah.
I didn't know we were supposed to write
Samir,
it.
what did Samir have before this? 3,900 or 4,000?
3,900.
Okay. Okay. I want to make sure it didn't
That's
do
what
it again.
Yeah.
Okay, we have a new winner
Yay.
of Perfusion in Jeopardy. Lindsay with 4,000 points. Samir, 3,900. And Daphne, you got some wrong, but you got
You were
a lot
here.
right too. Daphne, you
I
did
learned how
about
to play. You know,
you
that's
did
what
way
matters.
better than I would have done, so no worries.
Come back and play next time.
If you
Oh, yeah.
in the audience would like to participate, we would love to have you join our show here. If you live in this local area of Houston, Spring, the Woodlands, around there, please contact us at info@mediweb.us, and maybe you too can be a contestant on Perfusion in Jeopardy. Thank you so much, and we will see you on the next show. Goodbye.
That wraps up this episode of Perfusion in Jeopardy! Thanks to our contestants and to you for watching. From MediWeb Studios, we'll see you next time.
And there you go, everybody.
There you
That
go.
concludes our. You changed
I was
very
robbed.
quickly, Samir.
I do.
Why did you
I
change so
changed.
quick. You got robbed.
That's
You cheated when it was me.
No.
Okay, she didn't
I was-
cheat.
I
She
was
knew
legit robbed.
She knew the answer. She actually mouthed it. I was watching. She did not cheat. She knew the answer, and she bet that 1,000. You knew the answer too, but you didn't bet anything.
I
So it
didn't bet
doesn't matter.
nothing.
You could say the answer doesn't make any difference. It would have been the same thing. So
I was betting that she wouldn't know the answer,
that
and I didn't want to be
no.
wrong.
You know what you told me when I lost? You said, "Dude, you know you lost just because you didn't play a good Jeopardy game."
That's why I lost.
agree. You lost because you didn't play the game.
That's
dude.
exactly what
She
happened.
Beat you, okay? Fair and square.
You're right. You're right.
No cheating. I
There
watched
was
the
no
whole thing.
cheating.
All right.
No, no, no.
With all
I'm
that
not saying I was
said-
cheating. I was saying I was robbed.
You weren't. No, you weren't robbed. You were outplayed, my friend. You were outplayed.
I was outplayed.
I'm
You're
very
right. You're
proud
right.
of
No,
you.
that's exactly what
Outplayed.
happened. I was
Okay,
outplayed.
We're coming back. We're coming back.
We are
I'm
coming
back to the next one. All right. We hopefully we'll get some contestants. Look, if you're out
Yeah.
there in web world, you know, I know David will probably if he David gives a really funny look and he looks like he's packing his shit to quit. I think you could do it remotely. I think there's a way we can make this happen.
Oh, yeah.
So would be better if you came to the studio if you were local or whatever. That'd be great. But if not, there's got to be a way for us to be able to do this remotely, and do the game from there.
I don't think the
So,
buzzers would work.
well, the buzzer might not work, but we could have a surrogate in there to push the buzzer, and the person does the
No,
answering.
there's a delay. That's a delay. You can't have a delay. These things are
No, the
like at the
person
moment.
a surrogate in the studio.
Oh, yeah, I see
who
what
is
you're
the
saying.
buzzer pusher? There's no delay. I'm sitting right next to you.
Okay.
And so, then it's a matter of they would just have to accept the fact that I am going to play my game, but they have to answer the questions.
I love
so
it.
it could be ugly. It could be ugly. It could be good. It doesn't matter.
No.
Because you're not winning money. You're
No,
winning
no,
bragging
no.
rights.
Yeah.
You're not winning any money, right?
No.
There's no money.
No, we
But
want a
it's-
mug
this
though.
is- And this is about education. You're not getting a mug either. You know what? You're banned.
Oh.
You're banned from having PerfWeb
Oh.
because you're already complaining about being robbed. So you're not even allowed to have a PerfWeb.
I did
mug.
win my own mug.
In fact,
I
if
like
you
my
have one,
mug.
you have
It
to
was
bring back.
exciting.
I want it back. I want it back.
No, you're not getting my mug
Anyway,
back.
with that
My
said,
mug.
everybody, this has been a lot of fun, and we'll see you tomorrow. We're going to be talking about the transonic ELSA and
yeah.
why that should be a standard of care going over recirculation in VV ECMO. So we will see you tomorrow. I believe it's around 4 o'clock, if I'm not mistaken.
4 o'clock.
So we will see you tomorrow at 4 o'clock. I may be in the studio. I may be remote. I'm not exactly sure yet. So I'm working out those details as we speak.
I'm clinical tomorrow, so I'm not. It's an early case, so I'll try to make it here after. We'll see how it
Yeah,
goes.
we'll see.
Obviously.
We'll see. I'm going to do my darndest to get there. I really am. I think I can make it, but it just may be tight. You
Okay.
know, and that's it. But we'll figure it out.
Yep.
Thank you, Samir, for all
Yes,
your
sir.
help again, and thank you to the audience, and thank you, David and Magic in the studio, for making us look so good despite being so horribly bad. And we'll see you next time. Bye bye.
All right. Bye, everybody.